All right, let's jump right into infective and non-infective inflammation of the GI tract and go through this exactly the way I'd walk a group through it live. I don't want you to just think of the gut as a simple digestive tube. Think of it as a highly active, microscopic battlefield. Every single day, your normal physical defenses are constantly fighting off outside invaders, neutralizing harsh chemicals, and sometimes even fending off friendly fire from our own immune system. Here is our agenda for this explainer. We'll hit the vocabulary of gut inflammation, causes by GI region, mechanisms of mucosal injury, red flags and symptoms, and finally, diagnosis and exam traps. Section 1, Vocabulary of Gut Inflammation, setting the rules of the battlefield. Before we get into specific diseases, we really need to agree on some vocabulary because these terms get thrown around way too loosely in clinical settings. First up, gastropathy. And the same logic applies to enteropathy, by the way. Gastropathy means the epithelium is damaged, but there is little or no inflammatory cell infiltrate. Think about physical or chemical wear and tear, like NSAID injury or alcohol consumption. The tissue is damaged, sure, but the immune cavalry hasn't actually arrived yet. Gastritis, esophagitis, and enterocolitis, on the other hand, all mean true inflammation. There's an actual infiltrate of inflammatory cells sitting right there in the mucosa. So when you see gastritis on a histology report, you should expect to see lymphocytes, plasma cells, or neutrophils, not just the physical epithelial damage we saw with gastropathy. There's also a specific modifier worth knowing: active inflammation. That specifically means neutrophils have actually crossed the basement membrane and are sitting directly inside the epithelium itself. I really want to emphasize this. That is never normal, anywhere in the GI tract. The second axis we have to look at is non-infective versus infective. Non-infective causes are things like chemicals, autoimmune attack, ischemia, or allergy. Infective causes are your viral, bacterial, fungal, or parasitic organisms. Basically, disease happens when a pathogen or irritant overwhelms the gut's normal defenses, like the mucus bicarbonate layer, rapid epithelial turnover, gastric acid, secretory IgA, or the microbiome, or when the immune system literally mutinies and attacks the mucosa itself. Section 2, Causes by GI region. We're going to walk through 3 regions: the esophagus, the stomach, and the intestines, because each has a totally different balance of infective and non-infective disease. Starting with the esophagus, non-infective chemical causes really dominate here. We're talking alcohol, corrosive acids or alkalis, pills that lodge and dissolve in the esophagus, radiation, chemo, graft-versus-host disease, and of course reflux, or GERD, and eosinophilic esophagitis, which is allergic. The infective culprits, like CMV in Canada, mostly show up as opportunistic invaders in immunocompromised patients, though HSV can occasionally occur in completely healthy people. Moving down to the stomach, we see a fascinating split. On the non-infective side, you have NSAIDs, alcohol, severe physiological stress like shock or burns, and importantly, autoimmune atrophic gastritis. But on the infective side, Helicobacter pylori stands completely alone. It is by far the undisputed leading cause of chronic gastritis worldwide. And then we reach the intestines. This is where infective disease absolutely dominates the playing field. Just look at this rapid-fire list. Toxin-producing bacteria like Vibrio cholerae and E-tech, invasive bacteria like Shigella, Salmonella, and Campylobacter, systemic diseases like typhoid fever, viruses like norovirus and rotavirus, and parasites like Giardia and helminths. Section 3, Mechanisms of Mucosal Injury. Let's talk about how the damage is actually done, because understanding the mechanism is where the infective versus non-infective distinction really matters clinically. Let's start with chemical and reflux injury. This one is a direct physical assault. Acid or caustic substances simply damage the epithelium. GERD specifically happens because the lower esophageal sphincter relaxes transiently and inappropriately. This lets gastric acid sit directly on mucosa that just isn't built to tolerate it. Now compare that simple chemical burn to H. pylori. This is a beautiful example of bacterial adaptation. It has flagella for motility so it can swim right through thick mucus. It uses urease to convert urea into ammonia, allowing it to survive that intensely acidic stomach environment. It has adhesins to stick tightly to the epithelium, and the more virulent strains actually inject a Ka toxin directly into host cells, driving chronic inflammation, atrophy, and eventually intestinal metaplasia. Contrast that highly evolved bacterial invasion with autoimmune gastritis. It's a completely different mechanism. Here, CD4 positive T cells launch a mutiny and attack the parietal cell's proton pumps. You lose acid production, sure, but crucially, you lose intrinsic factor. And that loss of intrinsic factor is your direct, straight line to B12 malabsorption and pernicious anemia.
And for the intestines, cholera is the classic toxin-mediated mechanism you have to know cold. The toxin locks a G protein in the on position. Because of that, cyclic AMP skyrockets, chloride channels open wide, and you get massive secretory diarrhea. And the crazy part? This happens despite the bacterium never actually physically invading the mucosa. Contrast that with Shigella, or Campylobacter, which physically invade the epithelium to cause an inflammatory, often bloody, dysentery.
Section 4. Red flags and symptoms. Spotting the enemy. We've covered the theoretical mechanisms, so let's connect all of this to real-world clinical application by looking at the symptom patterns. This table right here is your ultimate clinical cheat sheet. Notice the key differentiators. In the esophagus, odynophagia, which is pain on swallowing, is your major red flag for infective esophagitis. GERD typically gives you heartburn and regurgitation post-meals, but dysphagia and food impaction in someone who doesn't respond to PPIs, that classically presents as eosinophilic esophagitis. In the stomach, H. pylori is often surprisingly silent or just gives vague dyspepsia. Meanwhile, autoimmune gastritis takes decades to become symptomatic, and when it does, it's the B12 story, megaloblastic anemia and glossitis. Down in the intestines, it's all about the diarrhea pattern. Watery, high-volume, rice water stool points you toward cholera or a toxin. Bloody diarrhea with cramping points to an invasive physical attack. Section 5, Diagnosis and Exam Traps. Spotting the symptoms is just the start. We have to definitively confirm the diagnosis, but we have to avoid a massive clinical trap along the way. First, here are your diagnostic workhorses. For the esophagus and stomach, endoscopy with a biopsy is your absolute go-to. It lets you see the lesions and get tissue for histology. For H. pylori, you have great non-invasive options, like the urea breath test or stool antigens, or you can do a rapid urease test on a biopsy. For autoimmune gastritis, you're checking for antibodies against parietal cells and intrinsic factor, along with low pepsinogen and B12 levels. But when you hit the enterocolitis, down in the intestines, stool tests absolutely rule the day. Cultures for bacteria, O&P for parasites, and PCRs for viruses. But here is a clinical pearl you absolutely must commit to memory. If you have a patient with bloody diarrhea and you ever suspect EHEC, specifically the O157H7 strain, do not reach for antibiotics. If you kill the bacteria, they release massive amounts of Shigella toxin all at once, which actively increases the patient's risk of developing deadly hemolytic uremic syndrome. It's a classic exam trap and a very real critical warning. Which brings us to the future. We've seen how beautifully adapted these pathogens are, and we know that relying blindly on antibiotics isn't always the answer. Sometimes it's exactly the wrong answer. So, as antibiotic resistance continues to rise globally, how will this delicate battlefield between infective invaders and our gut defenses evolve next? It's a serious question that medical science will have to answer soon. Thanks for joining me for this explainer, and keep learning.